Rich Iorio's big on this, particularly when we've gone to bundled care payments. We have a perioperative surgical home, and we've tried to optimize a lot of our patients and reduce their overall costs and their wound complication rates with a number of these interventions. You can read, and he's presented it in August. We looked at our infection rates at our house with a number of different interventions. We're now going back and looking at this for knee replacements. I think actually, interestingly, one of the largest changes we've had in terms of our wound infection rate is associated with going to aspirin as our primary thromboprophylaxis prevention. We then did a whole bunch of other things, including adding betadine and vancomycin to the wound. And I know this does go against some of our national NIH recommendations, but we're doing iodine lavage and vancomycin powder. And what we found was this cut our infection rate in half. Although, despite all of our best efforts, our odds ratios for infections were 2.2 times higher if you had an anterior approach. So I would suggest to you, if you're doing an anterior approach, start thinking about some of these secondary issues for wound management. And again, before and after our vancomycin and povidine and betadine washes, they went down. The consensus suggests, supports the use of betadine as an irrigant at the time of surgery. There was a recent paper out of Mayo where they didn't see a benefit, although I would suggest they may have a beta error. The numbers were not as high in the betadine wash. Rafa could maybe speak to that. Wound complications are the #1 risk for our hospital readmission, and when we looked at our all-comer complication rates with our total hips, 55% of them were associated with superficial deep infection and prolonged wound drainage. So this is actually the majority of our current complications with total hip replacements. Staples versus sutures. We looked at this. We did a systematic review. We did a meta-analysis. We concluded that staples had some subtle advantages. The consensus was a little more bland on this topic. They said there's not great evidence of one over the other. So when I see these wounds in the office, and I'm afraid of these complex wounds, what do? If they've got a wound at risk, I stop their physical therapy. I'll actually sometimes put them in a knee immobilizer, apply compressive dressing. If they were on a higher dose anticoagulant for a while, all of our patients over a BMI of 40, we were putting on a higher dose anticoagulant. I've started to reconsider that and consider the use of a wound vac even in a delayed fashion in the office. So risk stratification, we use an algorithmic approach. We sort of customize our care. There's a little bit of individual opinion that goes into this, but taking into consideration all the local, systemic, and environmental factors. The vast majority of these, we use an inclusive dressing. So at our center, everyone gets one of these inclusive silver impregnated dressings. There are a number of companies that make them. We leave this on for 7 days. We've had delegates at some of the meetings who've come up to the podium or to the microphone and said this is heretical. You have to look at your wounds twice a day. But I would suggest to you leaving it covered is a nice barrier. It prevents touching hands, and the visual examination of a wound that's covered I don't think provides any significant benefit. It's reduced the risk of infections at a number of centers. Here's Rothman's data. Here's the data from Columbia, 4-fold decrease in their prosthetic joint infection rate. Here's Brian Springer's work down at Ortho Carolina with a randomized controlled trial. Obviously smaller numbers in that setting, but they showed significantly better patient satisfaction with the use of these. We looked back and did a meta-analysis on this and found, again, significant benefits associated with these hydrofiber dressings. And the consensus supports this statement, with silver dressings being shown to be an effective tool for reducing PJIs. They also support leaving the dressing on, so not examining the wound and leaving this on for 7 days, and a minimum 48 hours unless there's an issue. Our higher risk patients, We developed this fancy term I call PASTI, the para-articular soft tissue envelope. So if you've got a big, heavy soft tissue envelope, we put a wound vac on all of these. And I think we've evolved ahead of the literature, perhaps, in our practice. A wound vac provides a lot more benefits than just sucking on the wound. It has a whole bunch of effects on the soft tissue, the lymphatic system, swelling, and the partial pressure of oxygen. So there are a myriad of different ways in which this helps out with wound healing. It also provides a sterile seal to the wound. Lots of data now supporting the use of wound vacs in different areas, and some algorithms on when to use it. I think there are 3 specific intervention times. The high-risk wound in the OR, that's 90%, 95%. The post-operative wound drainage in the hospital, so if you missed it and then they get to the floor and the drain, if you can apply it on the floor. The wound breakdown in the office, obviously a more rare situation, but perhaps a benefit, not by putting your head in the sand about infection, but in the rare case of wound drainage later. So this is a vast majority of the ones in our case. Scenario 2 in the hospital, and scenario 3 in the office. Matt Austin and the guys down at Rothman published their paper on putting this on in a delayed fashion. They did identify that if you're on a high-dose anticoagulant, you've got a higher risk of complications, but other than that, they had a reasonable success rate. We've enrolled patients with primary total joints with a BMI over 35 into a randomized controlled trial. We're about halfway through. We're still underpowered to show a significant benefit, but we are seeing a trend towards reduced complication rates associated with the wound vac in these heavy patients. In the General Assembly, again, they support the use of wound vacs in high-risk patients, although I would say this leaves a little open to interpretation on who that high-risk patient is. This is in revisions. John Cooper published a nice paper when he was up at Lenox Hill on diminishing the infection and complication rates in revisions. There's currently a multi-center randomized controlled trial. We're doing this, we're participating. Carlos Laverni is running it at Joint Disease, so we'll see the results of that. Current challenges, they're costly. You have to have them in the OR. Patients don't tend to like them as much. They beep. There are some smaller, more portable devices that we use in selected cases. These are not for the high exudate, but the more prophylactic application with the lower exudate. I think these are a nice option. So in conclusion, wound complications are the #1 risk for readmission after total joints. We've developed an algorithmic approach to what we do. We use inclusive dressing for the vast majority, but in high risk, we've gone to these wound vacs, and we've been very pleased with the reduction in our wound infections. Thanks very much.
Última plática